I'm Carrie Firestein, Chief Executive Officer of Allied Physicians Group, practicing pediatrician for 30 years, mother of 3, and now grandmother of 1. This past Saturday was Autism Awareness Day, World Autism Awareness Day, and on Friday my office wore blue, and we were all standing in support of all of our families with children with autism. And Allied felt that going beyond that and offering education and answers and resources is the best way that we could celebrate World Autism Awareness. It's hard enough being a parent when your child is neurotypical, when your child has concerns. Is this development normal? What's going to happen? It becomes even more concerning. That's where it's great to have a pediatrician that you can count on, that you can work with as a partner so that we can figure this all out together. Allied Physicians Group, we are a group of 150 pediatricians in 34 offices, going from Riverhead out to Staten Island and into Westchester and Monroe, New York. Our physicians are all dedicated and educated, and we work with our families and we help you figure out how to make your child be the best that they can be. So today we have 2 of those physicians here with us, as well as a psychologist who is going to help answer lots of your questions. There will be lots of questions that we don't get to, and if you have any, we will do our best to get you some answers to those tonight, or give you some resources that you can connect with to get more answers. And then there's always your pediatrician who you can speak to. So I am going to let our wonderful panel introduce themselves. Dr. Jamie Parles, do you want to start?
I'm Jamie Parles. I'm a pediatrician. Did general pediatrics for 28 years. 6 years ago, I started a behavioral only practice where I treat children with a variety of mental and behavioral health problems, including a large number of children and teenagers on the autism spectrum.
Hi, my name is Clifford Maz. I'm a pediatrician. I've been in practice for over 32 years. I have a subspecialty in developmental behavioral pediatrics. And currently I dedicate a significant portion of my time in diagnosing and treating children with developmental disorders, of which a great majority of them have been diagnosed with autism spectrum disorder. So I'll plan on giving an overview tonight on what I see in primary care.
And Dr. Deborah Reicher.
Hi, good evening, everybody. My name is Deborah Reicher. I am an assistant clinical professor and clinical psychologist at Stony Brook. And prior to that, my roots are in special education. I was at the Hagedorn Little Village School for 20 plus years before making this move. Most of my career, including my fellowship and forward, has been spent working with families and children on the autism spectrum. So my current position includes doing a lot of diagnostic evaluations with children of all ages, from babies all the way up till 21, working with families, and also I have a therapy caseload. So I'm fortunate enough to get to work with these kids on an ongoing basis, some of them even after the diagnosis. So I'm the first portion of tonight, and I have a PowerPoint where my goal is really just to go through the symptoms of autism spectrum disorder, to talk a little bit how higher functioning individuals with autism might look according to these symptoms. And even I have the word high functioning in quotes because there are some people who object to the terminology, especially a sector of people with autism themselves, because what does that really mean and whose judgment is functioning? But I'm using it just because for ease. And when I talk about high functioning autism, I'm really tonight talking more about kids who are close to average cognitively. And that's sort of the way I'm going to delineate it. So we can go on to the next slide. So years ago, I used to always use a statement when I was teaching, and it was, if you know one child with autism, you know one child with autism. And a lot of people in the field know that term to describe just the variability of individuals on the spectrum. And then when I was at a conference, I saw somebody apply this Andy Warhol pop art Campbell soup picture, and I loved it, so I took it, but I gave them credit. But I think it just describes autism beautifully, because everybody who is autistic has the same Campbell soup label, but the ingredients, if you're a soup person like I am, are so vastly different, between like a chicken noodle and a New England clam chowder and a split pea. So while the label's the same, the ingredients have so much diversity and variation. Next slide. So I think related to that is the concept that the autism spectrum is not a linear spectrum. And with that said, this little cartoon I found on an autism website, and I think that that's a better depiction of what the spectrum is for those of us who either have autism, know someone with it, or work with autistic individuals, that just because you're on the spectrum doesn't mean that all parts of you are the same as others on the spectrum. And there are plenty of autistic people who have parts of themselves that are very much like neurotypical people. So it doesn't necessarily mean that the whole person is encompassed in the same way. You can go to the next slide. So I think when the we actually just came out with the DSM-5R, and I don't have that on this slide, but just like a couple of weeks ago, we updated the diagnostic manual. And I think for families and individuals with autism, one of the questions when the DSM-5 came out, and they went from having these categories under pervasive developmental disorders, where we had autistic disorder, and then we had pervasive developmental disorder not otherwise specified, and then we had Asperger's. They were all intended to be autism spectrum disorder, but it got a little confusing. And that was the reason why the DSM-5 just made everything autism spectrum. There was a fear that we were taking something away, and that people with what was formerly known as Asperger's would kind of lose their services. And that really wasn't the intention. Most people with Asperger's were subsumed under the autism spectrum diagnosis. And Asperger's, the definition of it was, when I started my career, there was no Asperger's 32 years ago, and then it came into the DSM, and now it's back out. But really what it was is it was a person who had autism, but they didn't have the language delay or the cognitive delay. And one of the reasons it was removed, aside from the confusion of the different terms, is that the research really shows that they look very much like high functioning people with autism, and there's not really a distinction. With that said, I still like the Asperger's term, and I find people with Asperger's embrace the term, and it's an identity. And when I work with families, a lot of times I will use Asperger's, and sometimes it's a little bit more easily digestible. And I have a lot of kids who love referring to themselves as Aspies, or and they make puns, about the term. So I still like to use the term. Next slide. So I'm not going to go into painstaking detail about the DSM criteria. What I'm going to do is in the slides in between the actual diagnostic criteria, I'm going to try to talk about how some of the symptoms manifest in this particular group of autistic kids. So just an overview of the diagnostic criteria. There are two sort of behavioral clusters that the diagnosis includes, and one has to do with deficits in social communication. And then the other one has to do with a pattern of restricted, repetitive patterns of interest and behavior. So I'm going to touch on both of those. So for the first set, this is the social communication set. You need to have all three. And if you flip the slide, I'll go through how some of them might manifest. So these are just some examples of things you might see. Before I even start with this, one of the myths, which there are many myths about autistic kids, but one is that they are not interested in interacting socially. And that it might be the case at times, but it certainly is not universally the case. And often with higher functioning kids, they do want to interact socially. They just might go about it in an unusual way or lack the tools to do it effectively. One characteristic is sometimes not sharing or responding to other people's feelings. But on the other side, I see a lot of kids, especially this particular group, that are more like empaths, where they actually feel other people's feelings. So it can be either way and really anything in between. Difficulty expressing feelings is a common symptom and common challenge. And sometimes kids with autism won't even really know what they're feeling, or sometimes describe themselves as not feeling anything. There's a clinical term for that called alexithymia. Making socially inappropriate responses. So sometimes, especially these higher functioning, bright kids will do something like challenge a teacher because and a lot of times they're right. They'll challenge the teacher because the teacher got a fact wrong, and so a neurotypical child might know, well, I shouldn't challenge a teacher, but the child with autism will because the fact is a fact. Not to be rude, sometimes it's misconstrued as rudeness. Difficulty with give and take activities, difficulty initiating or sustaining conversations. And as this happens, and we'll get into the special interests a little bit later, but especially talking about things other people are interested in that they're not interested in. Poor eye contact, but also unusual eye contact. And again, there are plenty of people with autism that have decent eye contact. So no one of these symptoms alone can be used. With the unusual eye contact, I noticed that sometimes higher functioning kids with autism sometimes will have a staring quality, and it can feel uncomfortable. And I've noticed with other kids that they've learned to give eye contact through the therapies and over the years. And sometimes I will see that they're not actually looking in my eyes, they're looking at my glasses or at my eyebrows. Flat facial expression, or sometimes, again, the reverse can be true too. You see a lot of kids with very exaggerated emotional expressions. Something sometimes is unusual about the pitch or the tone of voice. Sometimes kids will sound a little bit flat. I mentioned the peers not necessarily having a limited interest, but maybe not knowing how to go about interacting. Asking inappropriate questions, sometimes as a way to try to reach out socially and not having a social filter. I had one kid, for example, who his icebreaker was, are you gay or are you straight? And for obvious reasons, that wasn't working very well. But he was really trying to reach out socially. And that leads into, adapting behavior to different social contexts. These high functioning kids, sometimes their play skills are good. They're pretend, again, another myth that kids don't use their imagination when they have autism. But some of these kids are very, very bossy in play, and you can see where this would trip them up with peer interactions. Parents will report, that their 3 or 4 year olds will play, but you have to have a very specific role, like, no, mommy, and right down to the script. They'll actually tell you sometimes what you have to say. And this might work well when the child isn't in school, but once the child gets to school, it interferes with the peer relationships. And sometimes in their efforts to reach out, they don't always know when they're being annoying. And then sadly, a lot of times don't recognize when they're being rejected or bullied. Next slide. So the next set of diagnostic criteria, as I said, have to do with restricted repetitive patterns of behaviors, activities, and interests. And there are 4 here, and you need to have 2 out of the 4 to meet criteria for the diagnosis. So I'll break it down a little bit and talk more specifically about what I see with these kids. You can change the slide. So repetitive play, playing the same thing over and over. Repetitive speech. So that is known as echolalia. So sometimes kids will repeat exactly what you said verbatim, and then other times kids will repeat things they hear on TV. It's known sometimes as either delayed echolalia or scripting, where they'll repeat like a commercial or something, and sometimes it's out of context, but sometimes it's in context also. I had one child many years ago, before we got to know him, he was scripting soap operas, and we thought, wow, something must be going on because soap operas have a lot of violent and sexual content. But it turns out the mom had injured herself and she was home with him in the summer and she was watching soap operas. So sometimes it's used in an interesting way and worth investigating. And then another more interesting version of echolalia is known as palilalia. And the reason I mention this is because I see it a lot in high functioning kids, and I'll explain exactly what it is right now. It's when the individual repeats their own speech, and usually they do a portion of what they said and it's in like a whisper. And it's subtle, but you can pick it up a lot of times. Unusual tone, high pitched. I mean, this has to do with the rate and rhythm of speech, or the prosody of speech. So sometimes you'll just feel like there's something off about the quality of the speech. And I had more than once kids speak in British accents when they don't have any roots in England. And sometimes it's like from Peppa Pig, but it's common enough to mention. And also pedantic or, professorial speech. Sometimes that's where I think Hans Asperger said these kids were like little professors. But just this week I had like a 6 or 7 year old use the word enigma, and also about 6 or 7 times he said per se, while he was speaking. Insistence on sameness and flexible adherence to routines, ritualized patterns of verbal or nonverbal behavior. So these kids are very routine bound. A lot of the time they have a strong need for sameness. Things have to happen the same way every time. So something like changing the route that you take to school could cause a meltdown. And in my experience in working with families, because the families to me are just as important to work with as the kids themselves, as a parent, nobody likes to see their child distressed. So parents will go to unbelievable, lengths to try to prevent meltdowns from occurring, and by walking on eggshells and altering the environment to try to prevent meltdowns from happening, and do the same thing over and over. Like I've had parents walk up and down the stairs a different way, or back up so the child can turn the light switch off first. I had one mom where the kid's milk brand changed, so she kept the old milk container for like a year and would always pour the milk into the container so the child would drink milk. But this, I think Dr. Parles is going to talk about behavioral stuff, but this rigidity really causes a lot of the meltdowns that sometimes are not understood. And I think, one of the pluses, if there are any, about getting the diagnosis is it puts some of these behaviors in context, and it helps families figure out what to do with them. So difficulty with transitions, a hard time changing your mind, being very rule bound. And sometimes these kids wind up being tattletales. So if somebody else breaks the rule in school, they have a really difficult time. I have a child now I've been working with for like 4 years who is just having a really hard time being a teenager, because teenagers do so many bad things, and he really has a hard time. And we've been working on helping him just worry about himself and not calling other people out or telling the teacher, because he's now 16. Things have to be just so, parents will keep toys set up, their whole den will have a, train set up and things lined up so they can barely even use the den, and just kids getting very agitated and upset if you mess their belongings up. And then this rigidity sometimes extends to food, which becomes stressful for parents, where kids can be very, very specific, have extremely limited diets. Sometimes we call it the beige diet, where they'll only eat foods that are beige, like chicken nuggets, French fries, Cheerios. And it becomes particularly stressful because parents obviously are worried about nutrition. Next slide. And in terms of highly restricted fixated interests, this is, for me, a very fascinating area. And I spend a lot of time with my therapy kids exploring their areas of special interest, because I think it's also important to consider the strengths of this diagnosis, because these are kids that have fantastic memories and capacities to find information and recall information. Sometimes when they're younger, they're preoccupied with parts of toys. So I've had families have little wheel collections from all the Matchbox cars, or pull the windshields off. Having a very narrow range of interests, some of them that are common. And again, none of these mean that a child has autism, and a lot of high functioning kids have interests that are developmentally appropriate, but it's the degree and the extent to which it permeates their day-to-day existence. But some of them are dinosaurs, trains, astronomy, World War II. I could spend a whole night talking about girls with autism, but girls especially, their interests a lot of times seem very developmentally appropriate. And again, it only becomes apparent that it's a special interest when you see how much it takes over the child's day-to-day functioning. And as I said, the great memory, the extreme preoccupation and engaging in repetitive behavior around the interest, like researching things, spending all day on YouTube looking up facts about the special interest. And another thing about special interests is sometimes they wind up becoming occupations. So, a lot of people with intense interests in technology or highly specific areas of like archaeology and other, it can wind up working itself into a successful career. So then the last one out of the four, where you need 2 out of 4 under the restricted repetitive, has to do with sensory. And so sensory, the thing that's sometimes confusing is that kids can both be over-responsive and under-responsive at the same time. So the same kid could fall and clunk their head and not come up, act like it didn't hurt and have a huge lump. And then that kid can't tolerate a tag in his shirt or, won't try a different texture of food. So some of these kids are overly sensitive to touch. They don't like seams. That kids, many kids won't wear jeans, but a lot of these kids can't handle any type of texture or button on their shirt. Some of these kids are sensory seekers. They'll crash into the couch or press into you, or they need to fall asleep twirling your hair. Grooming can be very difficult for some of these kids, even when they get into adolescence. That's why sometimes hygiene is not great, because things like washing your hair and brushing your teeth can be very unpleasant. Actually, just today, a mom told me that the experience of soap for this kid, it makes him feel like he's dirty because it's so slimy. So he doesn't want to use soap. And he's entering adolescence now. And so if you don't understand that and you just look at the child's hygiene being poor, you kind of miss the sensory piece. And a lot of these kids are overstimulated in crowds. And just thinking about school for a minute, school is sensory overload. And a lot of these kids, one of the biggest triggers for behavior in school is sensory. Next slide. So I'm going to just very quickly cover the severity ratings. You can go to the next slide. But so there are severity ratings, which I don't think at large the field is thrilled about, but it's a way of trying to categorize the severity. It's very important to parents. They usually want to know what level or where the child is on the spectrum. So there's some subjectivity, but there's level 1, 2, and 3, requiring support, requiring substantial support, and requiring very substantial support. And I just wanted to mention it because it is in the diagnostic criteria. Next slide. So just some points to remember with higher functioning individuals. The symptoms are supposed to be present early, but they can be masked, and they sometimes only become apparent when the social demands increase. And a lot of times even good testing like the ADAS can miss higher functioning kids because it looks at the child's relatedness with an adult, and sometimes high functioning kids do great with adults. Special interests, again, can be challenging to pick up on because they're sometimes developmentally appropriate. As I said, sensory issues can be overwhelming in school. And a lot of times these higher functioning kids are in general education, but general education sometimes misses what we call the hidden curriculum, which more has to do with the rules that aren't taught explicitly. And that's where social emotional functioning comes in. Again, eye contact's not a telltale sign. Kids with autism might want friends. Stims don't have to be present. If a child thinks he might be autistic or she might be autistic, listen, because I can't tell you the number of kids on the spectrum ranging from age 9 and up have sort of self-diagnosed, and they were right. And kids look up stuff when they feel like they don't belong. They go on, research things on Google, and a lot of times they're pretty accurate. And again, recognizing that some kids with autism don't recognize that they're being bullied. Next slide. Some of these points, I wasn't sure if it was mostly parents or physicians, but these were just smaller red flags that I've noticed over the years. And sometimes kids with encopresis who have trouble using the bathroom. I'm not saying that it means your child has autism, but there's a larger number of kids with autism with encopresis than in the general population. Sometimes diagnostic combinations, like if you have a child that's gotten like all different diagnoses, OCD, sensory processing disorder, ADHD, and anxiety, if you put that all together, it could likely be autism. Difficulties with emotion regulation and major meltdowns to seemingly minor antecedents. A lot of times if it is autism, it helps explain what the trigger is, which a lot of times has to do with rigidity. And even kids who get an ODD, oppositional defiant disorder diagnosis, not all of them, but some of those kids are on the spectrum, and it's the rigidity that's resulting in the oppositional behavior, because they're black and white thinkers who lack flexibility. And selective mutism in older children, also sometimes that can be overlap with autism spectrum.
This is me, meeting the needs of the child with autism in the pediatric office. The American Academy of Pediatrics is an American professional organization of 67,000 plus pediatricians who've developed guidelines for healthcare supervision. Their mission statement is to optimize the physical, the mental, social health, and the well-being of all infants, children, and adolescents. And that includes children with autism. As a physician, our responsibility is diagnose, provide a prognosis, which is difficult unless you have a diagnosis. And autism by itself is not does not help us to be able to predict what that child will do 20 years from now. And to lastly offer treatment. And in the field of developmental disabilities, particularly with autism, treatment is palliative, meaning we address the symptoms as long as we individualize what symptom causes the most dysfunction. In the past 10 years, I've sort of enjoyed, whenever I have to start considering medication, and I know that's Jamie's discussion, but whenever I have to consider medication for a child who presents with behavioral or emotional issues, I sort of preface it by saying that I have every single symptom in the DSM-5. That's what makes me a human being. So some days I'm anxious, some days I'm depressed, some days I'm inattentive. Really, the disorder is when it interferes with function. And often in the treatment options with children with autism spectrum disorder, we have to sort of individualize it. And this goes to Dr. Reicher's map of the Campbell soup with Andy Warhol. I need to sort of give you some bullet points because I know our primary care office visits are around 20 minutes. And I'm trying to consolidate, do an overview of what we do in the office. So bullet points, the Center for Disease Control and Prevention states that 1 out of 68 children will be diagnosed with autism in the next few years and have been diagnosed. The prevalence rate is 4 times more male than female. So the double X chromosome has a protective effect. There's an increase in genetic etiology based on twin study research. So it's more common in identical twins than it is in fraternal twins who share 50% of their genes. Also, we know that there's an increase in recurrence rate in families where first-degree relatives have autism compared to the general population. Causes of autism, again, bullet points. Genetic mutations, increasing numbers of duplication and deletion present with phenotypic expression of autism. Genetic conditions like Fragile X syndrome, like tuberous sclerosis, like Engelmann syndrome, like Prader-Willi, can present with autism phenotype. Metabolic disorders like PKU prior to the institution of the newborn screening test and nutritional intervention. Chronic exposure to neurotoxins like lead can lead to autism sort of phenotype, and severe prematurity. So those are the types of factors we need to keep in mind, especially when they come in for healthcare maintenance visits. Now, starting chronologically with infants, we cannot make the diagnosis of autism in the prenatal period or in infancy. However, if there is one sibling, an older sibling who is diagnosed with autism, we have to have an index of suspicion that possibly in the future that infant may end up developing symptoms consistent with autism. And I'm sure parents of that infant is likely to be hypervigilant and looking at a lot of symptoms to make sure that we can pick them up early, because we know early diagnosis, and everybody feels that early diagnosis leads to better outcome. So at every healthcare maintenance visit, it is sort of imperative that we as physicians address that because I think it's a major concern in the parents' mind. I have found that when there's a family member who's diagnosed with autism and subsequent children have mild delays, early intervention is more likely to sort of approve them for services. I'm not too sure that generic services do better. And there is ongoing research about early intervention starting at 6 months of age, but longitudinal studies have not been completed yet. Also in infancy, one of the major milestones that sort of can indicate a suspicion for autism in the future is joint attention. Joint attention typically emerges between 9 and 12 months of age, and it incorporates both social and nonverbal communication skills. Just by the infant looking at an object and looking at a caretaker, and the intuitive caretaker sort of guessing that he wants the pacifier, for instance, lead to pointing and being able to sort of getting what they want and need. You have to remember the goals of communication in the first 3 years of life is obtaining wants and needs. Often in the toddler years, when we see toddlers who seem to have expressive language lag, sometimes temperament, personality style, they may not be very eloquent or communicative, but they're able to get what they want and need by just pointing, which is a building block and a precursor skills for language acquisition. In the toddler years, and most well visits, parents talk about terrible twos, but really it starts in the second year of life. Toddlers' goal is to control, and that leads to a lot of temper tantrum and sometimes behavioral outbursts if they don't get what they want. The child with high functioning autism may have, just by definition, they should have age-appropriate acquisition of expressive and receptive language, and should have at least average intelligence. So those kids may sort of pass the screening and tests, but may develop sort of intense behavioral outbursts that are not consistent with the trigger. And I think Dr. Reicher pointed that out in one of her slides. So often we have to pay attention to those outbursts if they're associated with poor self-confidence skills, they're long-lasting, and they may not be consistent with the child's developmental level of function. At 18 and 24 months, we do the MCHAT, the modified checklist for autism in toddlers. And that's part of the well visit at 18 and 24 months. And if the scoring, which is done by the caretaker, indicates that there's a risk for autism, we as primary care physician usually refer to early intervention. The process is that they then evaluate and get to the diagnosis of autism. I have to say that most of the diagnosis of autism is based on an interview, observation of the child in a certain setting. The Autism Diagnostic Observation Schedule 2 seems to be the gold standard. It seems to make as a diagnostic instrument, but I have to tell you, at least in Staten Island where I practice, most of the early intervention programs do not administer the ADOS2. Usually a clinical psychologist, based on their clinical impression, may make the diagnosis. And after the evaluation, they usually come to the pediatrician, where they may have to sign for services like ABA or speech therapy or occupational therapy. But at that point also, the primary care physician should consider about the diagnostic entities that may lead to the phenotype of autism. The condition, as I said, like the DNA testing for Fragile X syndrome or chromosomal microarray. And according to the American Academy of Pediatrics, it is recommended that those two genetic tests be completed with the diagnosis of autism. You have to understand also that, as I said, our responsibility to provide a prognosis is significantly better if we know what condition leads to those behavioral symptoms. The recommended treatment for autism is ABA, evidence-based, where it's stated that 50% of the children who receive ABA services, which is a behavioral therapy using operant conditioning approaches that helps facilitate communication and social skills, but it also helps in minimizing maladaptive behaviors. The New York City Early Intervention Program approves 20 hours of ABA per week for children diagnosed with autism. Ideally, they should be evaluated by a board-certified behavior analyst to develop a specific program based on that child's individualized ability for function. Speech therapy, and you have to remember ABA services also help facilitate the delivery and the integration of speech and OT services. Occupational therapy is primarily provided to address fine motor and adaptive behavior, meaning daily living skills, and to also address sensory processing issues. Child is hyper-responsive or hyper-responsive to either tactile, to sound, gustatory stimuli. Not every occupational therapist, however, is certified in providing sensory processing or sensory integration services. I usually recommend, and for me, a good prognostic sign, even if I don't have a diagnosis, if a toddler is diagnosed with autism, if they start ABA services, if within 3 months of initiating those services, if they can develop or they're able to acquire eye contact and to point, for me, that's a good sign that they can continue to progress. It's hard to predict with autism because when we look at patterns of development, there are delays where those children who exhibit delays in development, many domains of development, can sequentially acquire these skills if provided the appropriate therapies. And there's a pattern of development called deviance, which autism spectrum disorders fall into, where you may have superior skills in one domain of development, and then deficits in other areas like communication or adaptive behavior. I had a child that I saw last week, 3 years, 2 months, who is, I diagnosed him with autism. He had superior skills, visual spatial skills, and was able to sort of do complex interlocking puzzle consistent with a 6 to 7 year old. However, he had a vocabulary of 6 to 7 words. The father was latching on to the visual spatial skills as possibly an indicator that he would be he would be in the high functioning range. It's hard to predict. I can say that I've seen children who had superior skills in one domain of development and with the appropriate, what we deem to be appropriate intervention, did not demonstrate much progress, and others who sort of basically got to the point that they fell off the diagnosis, because remember, the diagnosis is a behavioral one. So if you don't fulfill all the criteria for communication disorder, social emotional dysfunction, restricted or obsessive, restricted behaviors, and obsessive interests, then basically you don't sort of fulfill all the criteria. I do think some of those individuals do have residual characteristics that persist for life, though. At 3 years of age, that's when that child now enters the larger community, enters preschool. So often those characteristics that are taught in preschool, sharing, playing together with supervision from a teacher. That's when we tend to see more of these anxiety and behavioral outbursts, because particularly the child who has an obsessive interest in one particular area may not necessarily comply with the teacher's demands and requests. So often we get to see them because of behavioral problems that suggest either oppositional defiance or mood regulation type of disorder, impulse inhibition problems, or anxiety triggers. It's really kind of hard to pinpoint, but often, as Dr. Reicher pointed out, those toddlers, pre-K, and kindergarten children who present with all these behavioral issues may have a diagnosis of autism. And the issue would be to determine whether these outbursts, these defiance, these oppositional tendencies, those, behavior suggestive inattention are comorbidities or part of the autism spectrum behavior profile. The next area that we look at in primary care is adolescence. Most of the higher functioning children with autism tend to be good adolescents, meaning they're rule followers. In fact, I had a patient who at 21, when he left the office, he wrote a 3-page dissertation in which he concluded that autism was the latest stage in the evolution of mankind. To which I said, well, what do you mean, Anthony? And he said, well, society makes rules. I follow them. You don't. And it was very simple to him. But that is the crux of the problem of autism in adolescence, is that the whole goal, if you follow Erik Erikson's stages of development, it's that you achieve ego integrity and identity. And for the child, the adolescents with autism, they sort of follow all the rules at home. They're not defiant. They don't seek to sort of be with peers to sort of find who they are. And they follow that. Another child I had who was in the high school was bullied because at one point he saw teenagers, 10th graders, going out through a doorway where there was a big sign that said no exit. So he proceeded to tell them that they couldn't go out, and he became the target of bullies after that. They called him the sheriff of the town because he was following all the rules indicated. So many of these issues in adolescence of identifying who they are and feeling isolated sometimes because of a subset of kids with autism who want to be with peers but do not know how to manage these interactions or how to go about the process. But even those who want to achieve that, they have a difficult time feeling welcome or feeling that they belong or feeling that they fit in. I have this other patient who, at 20, he's attending college, who felt that because he was an adult now, he should have a girlfriend, he should have sex, but never understanding the process of how you get a girlfriend and how you proceed with a relationship. He just thought that by virtue of his age and his status as an adult, that's something that's expected of him. And more than the child who doesn't mind being alone, he as a young adult was probably going to suffer a lot from being isolated and being alone. And often the therapy that he required had to address some of these issues with fit, the issues of learning how to join a group, the issues of recognizing inappropriate behaviors and how to put himself in other people's shoes. In pediatrics, because our population is from birth till 21, we also have to prepare them for transition. I have to say that many of our adult physicians are not very comfortable with children with developmental disorders. And often they stay in the pediatric age group, although we would like to help them transition to adult programs. Now, often part of their transition may require that they be evaluated to see if they have the ability to be gainfully employed, to be able to live independently. I had a young man who was 25, graduated from John Jay, who basically was approved for Medicaid Waiver services through the Office of People with Developmental Disabilities last year, because he just couldn't take care of himself. He couldn't take care of his finances, although he was great at math, but he couldn't sort of integrate those skills into daily living type of function. So often I prepare the parents for the transition and often sort of recommend that they be evaluated with a psychological and violent adaptive behavior scale to see if they have the ability, despite what seems to be, they seem to be like very bright individuals, but they may not have the ability for self-care. And that's a difficult thing for parents to sort of address, and especially since they have to think about who will be their caretaker in the future when they pass. As I said, this is an overview, and we may have some more specific questions to deal with of meeting the need of the child with autism in the pediatric office. I've included, my only slide is a parent's guide to high functioning autism spectrum disorder, second edition. It's an excellent manual. I recommend the audible version.
Okay, thank you, Cliff. My topic is treatment of autism comorbidities with medicines. And I am not going to talk a lot about specific medicines. I'm going to talk more about situations in which medicines can be helpful to children with autism, really medicines to treat behavioral symptoms. So first of all, as you probably gathered, autism spectrum disorder is a widely variable and complex disorder. I don't want to be the third person on the panel to say that if you've met one kid with autism, you met one kid with autism, but I had planned to, so I'll do that anyway. I do want to distinguish the child with autism spectrum disorder who has normal intelligence and language skills from the child with severe nonverbal autism spectrum disorder, who often presents medical treatment challenges that really are outside the scope of a discussion of the length that I have available to me tonight. So I want to focus on like Deb and Cliff have on kids who have less severe disease. The treatment really needs to be individualized, okay? Not only to the symptom of the behavioral symptom that you're trying to treat, but also to understanding the psychological process that leads to the symptom. As you know, children with autism spectrum disorder, their brains and minds function differently, and what appears on the surface to be one thing can really be quite another. So, for example, child with autism, may appear to be drifting off and inattentive in school, looks like, he or she has ADHD, not paying attention, when in actuality, inside their mind, they're rigidly perseverating on the trivial misbehavior of a classmate that is making that child with autism really disturbed and robbing their attention from lesson time. That's just one example. I want to talk about a couple of behavioral characteristics of children with autism that lead to problem behaviors that often come to treatment, and they've come up already in one way or another in the talk so far. But the first one is rigidity. Okay, and rigidity is extreme, black and white, all or none kind of thinking, kind of thing where something is either good or it's horrible. Okay, it's either okay, it's either good enough or it's catastrophic with no in between, with no gray areas. And that sense of catastrophe leads to a psychological process called catastrophizing, where what might seem to others like a small problem, a small slight, a small insight, a small disappointment leads to a behavioral outburst, like what one might see in a catastrophe. Okay, if a house is falling down in an earthquake, the people inside it are acting like the house is falling down in an earthquake. They're going to act like there's a catastrophe. They're not going to be likely to be calm and going through their behavior normally. They're going to be upset and agitated, trying to save their lives. And that's an analogy that I often use for kids with autism who have these extreme behavioral overreactions to situations that seem like no big deal to most people. Okay, and with that in mind, I want to talk about the fact that it's commonly thought that having autism spectrum disorder makes one more sensitive to behavioral medicines or more prone to medicine side effects. And really, there's no actual proof of this. And from my clinical experience, I'm not really sure that that's entirely true. I think where that comes from is that the rigidity inherent in autism spectrum disorder and the tendency to catastrophize negative experiences can make many people with autism feel the negative impact of side effects more intensely and for a longer period of time. So remember that as kids being more prone to side effects, when in actuality, I think it's that when they have side effects, it's a bigger deal to them and their families. And that is a big deal. And we don't want to create those situations where our patients who are trying to help are made miserable for an extended period of time. So there is a need and a desire to be somewhat extra conservative, extra careful in prescribing, medicines when they are indicated for behavioral comorbidities in autism. The comorbidities that I'm going to talk about, each of them briefly tonight, that are most commonly treated with medicines are ADHD is one. The second is anxiety. The third is irritability and or aggression. And the fourth is sleep disturbance. ADHD is common in people with autism spectrum disorder. There's some disagreement as to how common it is. Studies range from 40% to 85%. It's probably somewhere in between that towards the higher end. ADHD causes a deficit in executive functions, which are the ability to have good control of one's behavior and emotions, and the ability to plan and organize one's thought, speech, decisions, and actions. Basically, they're the mental functions that that oversee all the rest of the mental and physical functions. That's, which is why they're called executive. It's what allows us to keep our mind straight and do what we want to do properly, effectively, and efficiently. And for people with autism who have ADHD, treating the ADHD, which can cause limited attention span, distraction, task avoidance, difficulty with task completion, forgetfulness, hyperactivity, impulsiveness, and frustration intolerance, and these things tend to have both academic and behavioral consequences. But treating that disorder, those comorbid symptoms, can allow better function in a wide range of circumstances and settings, and better engagement, with whatever non-medical therapies are needed to help that child with autism. And I want to take that opportunity to say that most of what's helpful for children with autism spectrum disorder is in the non-medical realm. As Cliff mentioned, ABA, which is particular behavioral therapy, as he said before. Much of the quote unquote treatment of autism takes place in school, where kids learn how to socialize, hopefully with adequate counseling and support that is that has expertise and experience in working with children with autism. Next comorbid condition I want to talk about is anxiety. Various types of anxiety are also common in people with autism spectrum disorder. It's social anxiety is often perceived in kids with autism. I think in large part because there are social deficits, and it can be hard to tell the difference between insufficient social abilities and skills from actual social anxiety. But in actuality, people with autism spectrum can have worries and discomforts, that are similar to people who are neurotypical. Okay, the origin of the anxieties and the types of anxieties can be very, very, very similar, although the way that the anxiety expresses is often different. Again, owing to those twin behavioral characteristics of rigidity and catastrophizing in people with autism. They're prone to feeling the negative emotion of anxiety in a more intense and difficult manner. So for example, okay, just borrowing from my practice, teenager with autism, terrified of storms, okay, because he is convinced that in a storm his house is going to be destroyed by lightning or a tree falling down and destroying the house, because he knows that can happen and has happened elsewhere in the world. So every time that there's a storm or even a storm predicted, he is just terrified and has extreme anxiety. The other piece about anxiety, as with regard to rigidity, is that challenge. Not only can the rigidity enhance the way anxiety is felt, but that challenging the rigidity of a child with autism spectrum can can cause intense anxiety that seems out of proportion. And for example, asking a child to eat a food that that child does not like the texture of can lead to a very outsized reaction, including refusal, yelling, screaming, crying, and if they do try it, gagging, spitting it out. It can be a real scene, and for people who don't have a sense of what it's like to live and be with a child with autism, it can be very confusing or disturbing, or sometimes unfortunately annoying because of lack of experience and understanding by a lot of people who really don't have the knowledge and experience of sorry, can't find the right word, of interacting with a child with autism. I forgot to mention particular medicines for ADHD, and I'm going to limit that to saying that there are both stimulant medicines and non-stimulant medicines, which are effective for different symptoms of ADHD or different circumstances in ADHD. And for children with autism and ADHD, either or both can be appropriate. Medicines for anxiety in people with autism, again, very similar to medicines for people with anxiety who are otherwise neurotypical. SSRIs like Prozac or Zoloft are very common. But really the whole range of medicines that are used to treat anxiety for people off spectrum are used for people on the spectrum. I want to talk about irritability and aggression because this is a real problem symptom complex in a subset of children with autism that's due to intense rigidity that causes them to feel minor demands or refusals as major, and larger demands or refusals as catastrophic. And these symptoms with extreme or aggressive outbursts can cause a substantial loss of quality of life, family disruption, and in the case of significant aggression, especially with the larger kids, can be dangerous. When non-medical treatments, and or treatment of other comorbid disorders that can lead to outbursts doesn't curb these symptoms, we need to consider, medical treatments that are specific to irritability and aggression in children with autism. Some of the non-stimulants that are used for ADHD, called alpha agonists, such as guanfacine and clonidine, can sometimes be helpful, in these situations, and tend to have a pretty benign side effect profile, but they're not always helpful. It's sort of 50-50 whether you're going to get enough help from that. And in those situations, we need to consider using a medicine from a class of drugs called second-generation antipsychotics, which are medicines that were originally devised to treat psychosis, illnesses like schizophrenia or severe bipolar disorder. And it turns out that for children with autism, studies show that two of them, Abilify and risperidone, can help with irritability and can reduce aggression. The problem is that these medicines have a potential for a much greater side effect burden. The most worrisome side effects is that a meaningful proportion of people who take these medicines have increased appetite, significant weight gain, and the metabolic consequences of that. There can be neurologic side effects. You can have acute movement disorders, which, you'd have to stop and not use the medicines. And there's a rare chronic movement disorder called tardive dyskinesia, or TD for those of us who watch TV, that for people generally to take high doses for a long period of time can cause uncontrolled small muscle movements, which can be debilitating, and for which there didn't used to be any treatment. But there's a new class of drugs which is now heavily advertised that seems to treat that. But these are side effects that one neither wants to have nor contemplate. The symptom burden has to be high enough to justify the risk of using the drugs. That being said, for certain kids whose irritability and aggression are extremely problematic and or dangerous, when these medicines are effective, they can be absolutely life-changing, making it so that children who can't function can now function. Families can, have harmonious time together, maybe go out to eat, go to a movie, go out in public without the fear of every moment becoming a disaster. These drugs should be used minimum effective dose for the shortest amount of time that they're needed. Although the truth is that some kids do need higher doses and some kids do need them for long periods of time. The ones that need them really should get them. These medicines should only be prescribed by someone that has significant autism experience and knowledge. Okay. And then the last thing I want to talk about is that a lot of people with autism have trouble sleeping, either falling asleep or staying asleep or both. And beyond the frustration and nocturnal disruption it causes to children and their families, it negatively impacts daytime function. Sometimes behavioral intervention with sleep routine changes and bedtime routines can be helpful. Sometimes not. Restoring normal sleep, with medicine when needed can be very important. Melatonin is widely used. It works sometimes, sometimes not. The go-tos with melatonin are use a low dose. A higher dose rarely makes any difference. Give it, 1 to 2 hours before you want the person to fall asleep. At least half the time, somebody who tries melatonin will have to progress to some sort of prescription sleep med. Ones that are often used are clonidine, which is an alpha agonist, like I talked about before, often used to treat ADHD, hydroxyzine, which is antihistamine, and trazodone, which is an old antidepressant that wasn't used much because it makes people too sleepy, but it's a very effective sleep medicine at low dose. And so, I think the take-home message is that in situations where non-medical interventions are insufficient to preserve function and quality of life, medicines should be considered to reduce symptoms and allow children and families to live their best possible lives, with the autism spectrum disorder. Thank you.
Thank you, Dr. Parles, Dr. Mevs, Dr. Reicher. So much information. My brain is hurting right now. We've spoken really for a long time, so I don't know how much longer people are going to want to sit through questions. What I'd like to start with, because there were a lot of questions about resources. You know, you talked about the needs, and almost every area of life, you know, is impacted. Does everybody need a team, and who should be on that team? And is that the school that is taking charge of that? Because, you know, most of these kids are getting services. Is that enough? And I know that if I want to call a developmental pediatric consult, I can't get somebody in until, you know, December. So what do we want parents to do? So I guess I'll start with Dr. Mevs. Who should be in charge of the care team? And then secondarily, do you have any resources, any groups for people to join that are helpful, that can help guide them through this?
Well, once they enter school, a lot of the services, at least in New York State, are provided through the school system. Services we talk about, aside from academic and educational, we talk about OT, occupational therapy, physical therapy, speech and language therapy, and ABA in some districts. But children with autism also qualify for what they call Medicaid Waiver services, which allows them to have a number of either respite or community rehabilitation services that are usually residential based, where these workers come into the house and, based on parents' interests, will take those children to sort of community settings like the gym, walk in the park, and social activities that include bowling, going to movies, and socialization skills. Now, they have to register through the Office of People with Developmental Disabilities, and to qualify and to be approved for that, you have to have either the diagnosis of autism. That's where the ADAS or some specific diagnostic instrument becomes important. Or you can have the diagnosis of intellectual disability, where an IQ test can qualify you for that. Now, the great majority of the kids will fall on the autistic spectrum. I mean, the traditional individuals described by Dr. Leo Kanner, they will test the sub-average intellectual range if they're provided a typical IQ, and if the test is provided in a standardized fashion. And especially if they have communication problems, they will score poorly at that. So they can get these services or access to these services through a case coordinator. Then the social worker at the schools may help them to achieve that. Now, there's care is individualized, as we all pointed out, like an adolescent, for instance, who's high functioning and may have anxiety symptoms and has interest in peer interaction. They can join a socialization group that also is achieved through the Medicaid waiver services. So the care team itself usually requires a physician involvement, but it's not that we all sit in a room and discuss as a group of interdisciplinary clinicians what would be the best treatment options. Usually it's so separate. I'll get a piece of paper, for example, from Medicaid waiver, and I'll give my impression, diagnostic impression, and they want documentation, but it's very rarely that we do face-to-face type of.
Well, that Medicaid waiver sounds like it would be an important thing to do. Dr. Wright.
They don't lose their family insurance. This is addition. It's almost like allows them to get access to the services that only sort of accept Medicaid. Sorry.
Dr. Reicher, when somebody is looking for a therapist to work for their with their child, is it important that it be someone who has autism experience? And we were specifically asked if you're taking patients.
I think no. Unfortunately, I don't have openings for therapy patients. There's a wait list for evaluations, but for therapy, there's such a shortage of providers in this area. Good providers who work with kids on the spectrum, both therapists, pediatricians, and child psychiatrists. Um, is it important that they specialize in autism? I think so, because I think, kids with autism present with a very specific wiring. And if you don't, for example, working with kids who are cognitively capable, I do cognitive behavior therapy because that's the most evidence-based therapy. And if you don't know how to modify the CBT to address the issues we've all been discussing, like the black and white thinking, and also incorporating the family. The family is so important. You can't just take a child in your office, do a 45-minute session. You have to collaborate with the family to help the skills generalize. So I think it is important that the professional have some specialty or at least experience with autism. And then
Is there something that a parent is looking for?
I think again,
name or something.
Well, just again, because the diagnosis is so variable, and so kids' needs range, from kids who might need an intensive ABA program, and like ABA is typically provided either through early intervention or through the school. And now in New York State, a lot of times, if you have a diagnosis from a physician, you can get ABA in your home. Many insurance companies will approve ABA in the home. And it doesn't always have to be traditional ABA. This could be like a whole discussion, but people think of ABA as being a lot of times kind of old fashioned, discrete trials, but the newer wave of ABA does intervention in more of a naturalistic environment. And some of the good BCBAs and psychologists that do that type of work will work on behavioral issues in the home with the family. It's a little bit different from what people think of as being, old-fashioned ABA. I think the question when you said who should be in charge of the team, I don't know if people are going to like the answer, but the family, it's your child, and no one's going to care for your child the way you do. And if you come along some really great providers along the way that love their work, the way I think the three of us do, they'll take your family on as if it's their own and give you as many tools as you can. But the parents, I think, are the best advocates for these kids, and the needs in the school system is so variable. And especially some of these higher functioning kids struggle the most when their needs aren't clear. And teachers are thinking these kids are being oppositional, or it's behavioral, or it's volitional, and the child is on the autism spectrum and the school district isn't looking through the right lens. And I've had to fight to get an IEP for a kid I diagnosed, a 10-page report with, a firm diagnosis, and, still arguing sometimes with gen ed teachers and, school districts that don't understand the hidden curriculum. So it can be challenging. It's most of the time it goes okay, but the times that it doesn't can be very, stressful for families. There's also advocacy like Long Island Advocacy Coalition, which I say if you're having trouble getting services through school, it's a useful free resource that you can contact, and there are advocates that will help you, fight for what you think your child needs.
Thank you. Dr. Pauls, are there any agencies that you like to refer people to?
No. It's sort of like not a fair answer, because it's, in 2022 April, it's not a fair question. An already broken system is severely overtaxed. The available, right now I'm hearing that for OPWDD, that the registration process for my patients that are applying now takes over a year. Okay, over a year.
Could you tell us what OPWDD is?
Oh, I'm sorry. Office of People with Developmental Disabilities, the New York State office that provides this, the services that Cliff was talking about before. Deb beat me to the punch. Absolutely. If the family is not the head of the team, okay, it is unlikely that the child will get what they need, because the system is fragmented. There are integration, true integration with people, with clinicians talking to each other is is the exception, not the rule. I know that I try very hard to make it the rule, not the exception, because it means so much to outcomes and how well kids do. But people are too stressed, don't have enough time, and there aren't enough of us, and there really aren't multidisciplinary centers that take care of kids with autism, which is really what kids with autism need. So I would recommend to families, go to the parent chat rooms, okay, and the other parents are going to tell you who to go to, okay. They're gonna, okay, because families of people with life-changing chronic illness learn pretty quickly, okay, and they learn how to tell the difference between between providers and clinicians who give care, and unfortunately, that is the state of the system right now, is to find somebody really good at what they do, regardless of what the discipline is, and let them help you with referrals, and that sucks, but that's the way it is. That's the way it is.
Talking about multidisciplinary care centers, I know that one is opening up in Syosset, called Cortica, from San Francisco. And I know one of the physicians and have met with her, and they're starting with a neurologist, and over the next 6 months are adding in all the different therapies. And it seems like it'll be a really good resource, hopefully, for Long Island. And they are taking appointments for neurology right now, if anybody's looking for something.
There is a difference, though, Carrie, between multidisciplinary and interdisciplinary. In general pediatrics, we sort of practice multidisciplinary approach, where if I send somebody to a neurologist, I get a consult. The interdisciplinary team approach is we all sit in a room. I'll sit with Deborah and Jamie and the speech therapist with the parents present, and we discuss what each discipline has found in terms of profile, come up with a diagnosis and a treatment plan. That can't happen because Jamie's right.
It's academic institutions. Stony Brook has, an interdisciplinary. We're working on, like, we just had speech join I have now speech therapists joining right after my ADOS. They observe the ADOS, and we have developmental peds, child psychiatry. We don't have OT and PT, but we do have, it's easier to fulfill that need in an academic institution.
It is.
Where we're all under one house. So we have, and the early childhood center that we just started, we're working hard to make really interdisciplinary, where I do my evaluations with a developmental pediatrician, and we work together for a lot of the really little ones that we see.
That's the model that needs to be implemented, and we don't have enough.
Yeah.
And Deb, the reason, that you're on this panel is because, of my what's the right word? My interactions, with the Stony Brook team, which is terrific and does a great job for a handful of kids.
Mm-hmm. Right. The waiting list is prohibitive.
Right.
It's frightening.
No, and that's not to minimize the job that you do, but you guys need 30 more people there, to scratch the surface of the needs in Suffolk County. And if you had 30 more people there, then you can really talk about having a real team approach. I mean, right now, it's a nod to a team approach because the impact is so limited in numbers.
I agree.
Dr. Mebs, are you taking new patients?
Yes, but there's a waiting list.
Okay. And Dr. Parles?
Yes, I mean, I am. I mean, I don't have a waiting list, but my next available appointment is not anytime soon, unfortunately, and which is painful to say, but you know, there's no way that I can change that, and without exhausting myself, and then I'm no good to anybody.
Well, so I think the take-home message is think in advance, right? You can't just let things go, because then once you decide you want to look into something, it's not going to happen the next day. So if there's thoughts in your mind, bring them up to your pediatrician. Parents can self-refer to early intervention. There was a question about a parent who didn't feel like they were getting the right answers from their pediatrician. You can self-refer to early intervention. And, you know, certainly sometimes it requires a separate visit to your pediatrician to say, this is important. It's not something I'm going to bring up, you know, at the end of the ear infection visit, but it's something I really want to talk to you about. Well, thank you, everyone. I think we covered a lot. We will send out the recording of this to everybody who registered as well as everybody who attended. I think we got through all the questions. When we send it out, we will look through if we have any specific organizations or providers, resources. We will include that in what we send out, because I'm sure everybody has, you know, a little notebook of people that they like. Whether you'll be able to get appointments with them is another story, but you know what? December will come. So get on the waiting list, and your child will likely still need help in December. And if they don't, and you cancel the appointment, someone else will be very happy. Well, thank you all. Thank you, Bree,
Thank you.
for setting things up. And happy Autism Awareness Day.